Assalamu alaikum. Inshallah, hopefully by the end of this session we'll be able to describe the anatomy and the biomechanics of the AC joint, as well as to describe the pathoanatomy and the classifications available for the AC joint separation, as well as the clinical and radiological evaluation, and finally to develop a comprehensive plan for management. For small displacements, the AC ligament, the AC capsule and its ligaments are the primary restraint for the posterior and superior translation of the clavicle. But when the loads become significantly higher, the AC ligaments maintain their role, especially the posterior-superior capsule. The conoid ligament becomes the primary restraint to superior translation due to its vertical orientation, and the trapezoid ligament becomes the primary restraint against the axial compression owing to its rather oblique or horizontal orientation. The primary functions of the AC joint within the shoulder suspensory complex includes the scapular adjustment on the thorax, as well as to aim the glenoid fossa for the humeral head to maximize the contact, as well as transmission of forces from the upper extremity to the clavicle. The AC joint motion is actually not related to the cardinal planes, it's related to the plane of the scapula and should always be coupled to the motion of the scapula. So with protraction of the scapula, which means internal rotation of the glenoid fossa, there is posterior widening of the AC joint and vice versa. The retraction of the scapula is associated with anterior widening at the AC joint. Anterior tipping of the scapula, which produces elevation, is always coupled to inferior widening of the AC joint, and this occurs to maintain the scapula on a convex thorax, and vice versa. The posterior tipping of the scapula or depression of the scapula is always associated with superior widening of the AC joint. And finally, upward rotation of the scapula is associated with anterior rotation at the AC joint, and this motion is mainly checked by the conoid ligament. So what happens with AC dislocations? What happens is that the clavicle remains seated at the exact same position. Nothing happens to the clavicle. What happens is that the scapula usually protracts, wings with inferior border prominence. As we see here, both clavicles are at the exact, both clavicles are at the exact same position. What happens is just the morbid anatomy of the scapula, which protracts, wings with inferior border prominence. The AC joint is not tolerant to stress, unlike the sternoclavicular joint, because of its small incongruent surfaces, articular surfaces, as well as the large force per unit area and the relatively low range of motion available. AC separations can contribute to 9% of shoulder injuries. They're actually more common in male athletes with various modes of trauma. It could be a direct trauma or an indirect trauma, or can be as a part of a spectrum of soft tissue injuries which occurs with high energy trauma. Rockwood classification is the most widely used for communication. It describes the ligament injured, the CC distance, the AC joint widening, as well as the direction of the scapular displacement. Types 1 and 2. Type 1 is just an AC sprain. Type 2 is an AC sprain with a CC sprain. Types 3, there is a tear of the AC and CC ligament complex with migration upwards from 25 to 100% of the distance. Type 4 is a pure posterior dislocation. Type 5 is a superior displacement of more than 100%. And type 6, which is rather rare, there is inferior displacement. So how do we criticize, how do we find this? How do we find the limitations of this classification system? First of all, there's an underrated role of the trapezius fascia as well as the posterior superior AC capsule, which takes us to another point, which is the underestimated dynamic horizontal instability with posterior impingement. And there's also a huge overlap in soft tissue injuries, which leads to confusion in the exact description of the grade of separation, as well as conflicting results in literature and lack of an agreement for the treatment of each type. Our decision is usually based on a two-dimensional static AP view, not taking into consideration the 3D rotational anatomy. And type 4, isolated type 4 and isolated type 6, they may not exist. I mean, they are very rare, or maybe not existing, because actually type 5 is always a combination between posterior displacement and superior displacement, and whether the posterior displacement contributes more to the instability, maybe it's a type 4. If the superior displacement contributes more to the instability, then it's a type 5. And of course, the most confusing part is that not all type 3s are alike. So this what made the Upper Extremity Committee modification through the ISACUS in 2014 to suggest these X-ray routines for the patient suspected with AC dislocation, the true AP, the Zanka view, the axillary view, as well as the cross-chest abduction view, or the Karl Basmania view, or the Alexander view. This view in particular can help to differentiate between stable type 3 and unstable type 3 dislocations, so furtherly subdividing them into a stable A and a stable 3B dislocation. Here there is no or minimal overlap in the cross-chest abduction view, but here there is severe overlap with posterior displacement of the clavicle on the acromion in the cross-chest abduction view. So evaluation should always include the patient factors, the duration, the radiological evaluation, as well as the clinical evaluation. It's always advised to assess the patient clinically while he is standing, to allow the weight of the arm to pull on the AC joints, to see the pain, the swelling at the maximum point of tenderness at the AC joint. Look for visible translation, whether anteroposterior or superior-inferior translations. And if the patient has more pain than expected, you might suggest a coracoid fracture or a severe posterior displacement with impingement. Several papers have discussed the presence of concomitant injuries with the AC joint. Teacher et al. Had studied 77 patients with types 3, 4, and 5, and he found that 14% of which had slap lesions, nearly 4% of which had concomitant supraspinatus tears, and 5% of which had concomitant fractures. Another multi-center study concluded by Arrigoni et al. Studied 98 patients, where he found that 50% of which had concomitant injuries, lying between chondral injuries, labral injuries, slaps, rotator cuff injuries, but only 30% of these 50% required additional treatments. With conservative treatment, it's always advised to refer to a physiotherapist initially in the first couple of days after injury to restore the scapular kinematics, as well as re-evaluation on weekly basis to assess the range of motion as well as the scapular motion. The provocative tests includes the horizontal stability, the cross-chest abduction test, the shoulder shrug. The shoulder shrugs means an intact deltotrapezial fascia, which may reduce the displacement of a type 3 but not a type 5 injury. You always have to look for the scapulothoracic joint while examining a case of AC dislocation, looking for the displacements which might happen to the scapula, which occurs in the form of protraction, winging, as well as inferior border prominence, and this should be a very important point in the differentiation between a type 3, which is going to be stable or unstable, which is the motion of the scapulothoracic joint. Radiology includes the AP view as well as the Zanka view, which shows both AC joints with 15 degrees Kefalad. The stress view to differentiate between types 2 and 3 by holding a weight of maybe 5 to 8 kilograms and comparing them on both sides. Some authors don't recommend the use of these stress views, and they say there is no clinical significance between a type 2 and a stable type 3 in the form of management. The axillary view can detect the posterior displacement of the clavicle and differentiate a type 4 from a type 3. However, it's sometimes difficult to make in the acute setting, and if you have a difference, a minor difference in the beam direction, it can lead to significant differences in the measurements that you will have finally. And there is, in normal shoulders, there is some posterior displacement, I mean some posterior direction of the AC joint regarding the clavicle. The Alexander or the Basmania view or the cross-chest adduction should be done if this instability persisting between 3 to 6 weeks and shows the overriding of the distal clavicle over the acromion. 3D CT is sometimes important for the better understanding and appreciation of the scapular malpositioning, as well as to exclude coracoid or scapular fractures and improve the reliability of classification as well as treatment. MRI is not done routinely, but can evaluate any other additional intra or extra-articular glenohumeral pathologies. Non-operative treatment can be offered for types 1, 2, and most of type 3s in the form of sling rest ice, as well as early physiotherapy, avoiding cross-body adduction and extreme forward flexion, with particular significance of the scapular balancing exercises. Good long-term functional outcomes may present later on at the long-term follow-up with persistent of pain or maybe persistent of instability with development of AC osteoarthritis. Regarding the operative management, there is no consensus. Again, who should have an operation, how and when, which operation. It's very, very controversial, but we can say that surgery is indicated for types 4, 5, and 6, if you ever see it. Type 3 who failed the conservative treatment, or the unstable type 3 with several techniques available. As said by Richard Hawkins, it's sometimes an operation waiting to fail. More than 60 techniques have been described to solve this issue, with several choices, with several options on your menu regarding the approach, the implant, the type of graft if you're ever going to use, and as well as the rehabilitation. From the earliest methods, which is the direct fixation, the Bosworth screw, as well as the direct reduction with AC joint, the Femster procedure, and these have fallen out of favor. The Weaver Dunn was described in 1972, in which there is a transfer of the CA ligament to the distal end of the clavicle associated with distal clavicle resection, with some modifications that this part of the ligament can be transferred with part of the acromial bone, as well as with augmentation with cerclage or any other implant for internal bracing till the healing occurs, and it could be done arthroscopically with various results described in literature with failures maybe up to 30%. The AC hook plate, again, it can the AC hook plate is not a reduction tool. It should be applied after reduction of your AC dislocation and should be placed in line with the posterolateral corner of the acromion or with the posterior border of the clavicle and not directly with the clavicular shaft. But it may need reoperation at 3 months for removal with acromial erosion and impingement of the rotator cuff. Internal bracing can be done whether open or arthroscopic, usually in the acute cases when no biological augmentation is done. Here, as we see, that the reduction is done by 2 button devices with high-strength tape in between, or on the picture on the right, or open tape with also bracing of the AC joint capsule. The AC joint capsule is very important for the horizontal instability, as the horizontal dynamic instability, especially as discussed with the dynamic form, and there has been several patterns described to brace the AC joint with tape and anchors. The anatomical reconstruction has been popularized by Mazzocca in 2010 using autografts, gracilis or semi-T or Palmaris, using a single tunnel or double tunnel technique with or without mechanical augmentation again. And again, it can be used open or arthroscopic, and the graft is looped under the coracoid with 2 tunnels for the conoid and trapezoid tunnels. So decision-making, patient factors, the age of the patient, the demand, if he's an athlete, is he in season or off season, Early functional rehabilitation with conservative management should be considered. 2 minutes بس. Acute versus chronic, again, no consensus. Most authors consider acute as less than 3 weeks. More than 3 weeks, it's chronic. So you always have to consider mechanics with as well as biology, and you can consider distal clavicle excision in severe chronic cases. AC ligament reconstruction, or I mean the AC joint capsule should always be considered for reconstruction or bracing to maintain the horizontal stability. Anatomic open or arthroscopic procedures are preferred options with better results and less complications, and always exclude coracoid fractures before operating, because this always bases your treatment. AC instability equivalent, if you ever see this, the AC joint separation with maintained CC interval, then you always have to expect a coracoid fracture, and this is when CT comes to a very important role. So to sum up, you always have to have proper understanding of the anatomy and the biomechanics of your problem, proper clinical assessment, not only radiological. There's no single best answer for our condition here. The non-anatomic reconstructions are biomechanically inferior to the anatomic reconstructions, but anatomic reconstructions may have slightly relevant increase in the clavicle and coracoid fractures. Always consider anatomical reduction of the CC ligaments as well as of the AC ligaments, and protect your reconstruction till healing occurs. So always think biology and mechanics. Thank you very much.